segments, which are fused together into one single bone.
That's good. Now know how many segments of cartilage you have, and how many pairs of foramen you have. Pairs of foramen you have. Sacral foramen.
I have sacral segments from 3 to 5.
Just read your little book. Figure it out. Okay.
Next. Okay. The vertebral column has a series of curves. The anterior posterior curves, which have the concave and the convex. And the concave is inward, and then the convex is outward. And then I didn't know if we had to know, like on the where it talks about how we have to know after birth, you know, how the thoracic and sacral curves begin, and then we don't have to know that part. Okay. And then lordosis is like meaning where you're bent backward. Describe the normal anterior concavity of the lumbar and cervical spine above, but also describe abnormally increased sway back.
My page is 290. A typical vertebra consists of 2 main parts. The body is one, and it's the weight-bearing portion of the vertebra. It also has flat and rough for the attachment of the intervertebral disc. The second part is the vertebral arch, which is the ring or arch of bone, which forms a circular opening called the vertebral foramen, which contains the spinal cord. And the second segment was on a vertebra, there are pedicles and spinosus processes. Pedicles extend posteriorly on the sides of the vertebral body, and the spinosus process extend more toward the midline of the vertebra. These are often palpated along the neck and back.
Okay, so when we look at that picture of a vertebra on 290, 9-6, you have vertebral body, behind it pedicle, then lamina, then spinous process, right? Learn them in that order so you know how to go backward from it. And the pedicle hooks into that vertebral body. The connection from the pedicle to the spinous process is the lamina. Know the vertebral arch. And then the inside there where the hole is open on 9-5, that's the vertebral foramen. Okay?
Okay, on 291, the intervertebral disc consists of the annulus fibrosus on the outside and the nucleus pulposus, which is soft and semi-gelatinous in the middle. And then when the facets of the surface of the superior and inferior articulating processes meet, the zygapophyseal joints are formed. Okay.
The cervical zygapophyseal joints are treated with C7 are better visualized in a true lateral, while the joints between C1 and C2 are better seen in a true AP projection.
Good one.
And then, since the cervical intervertebral foramina are angled anteriorly 45 degrees to the sagittal plane and directed 15 degrees inferiorly, it will take a 45-degree oblique position with a 15-degree valid angle in order to demonstrate.
Right. So what is she demonstrating with an oblique?
The intervertebral. Oh, the zygapophyseal joint.
Oblique. Oblique C-spine. Intervertebral foramen. Okay? And it's because they're at a 45-degree angle. They'll be wide open when we oblique them at 45 degrees. And then angle 15 so that we can see them. So for your test, you have to know which way to angle on the obliques, depending on which oblique we're doing, because the registry will ask that. But for practice and competency, you do not have to angle on your C-spine if the hospital doesn't. Okay? And for light practical, we're not going to angle down there because most of our rooms will use the CR angle. Okay?
I had page 293. The first cervical vertebrae is called the atlas. It doesn't have a body, just a thick arch or bone called the anterior arch, which contains a small anterior tubercle. The lateral masses support the weight of your head and helps rotate it, which make it the most bulky and solid part of C1. And then the second cervical vertebrae is the axis. It contains the dens, which is projected up from the body. Whiplash can cause the dens to fracture and can possibly result in damage of the spinal cord. And I'll do one more thing about the little... Okay. In order to take a radiograph of C1, C2, you have to take an AP open mouth or the Fuchs or Judd method. It is essential to position the patient correct so that the zygapophyseal joints are perfectly symmetric.
Anybody have any trouble identifying the zygapophyseals on 918?
No.
The E should be pointed toward the left one, and they're open.
That's it.
Page 294, the two articulations of the thoracic vertebral eye with the rib are the costrovertebral joints and the costrotransverse joints. And then there are 12 thoracic vertebrae. The first 4 are smaller, the last 4 are larger, and T5, T6, T7, and T8 are considered typical.
So they start small and go large. There are 12 of them.
The cycle form an angle of 7 to 75 from the MSP. So to open up those cyclophyseal joints, you need to oblique the patient at 70 to 75.
For T-spine.
Right, yes. And the openings is the intervertebral foramina. They're located at 90 degrees from to the MSP.
Okay, so the cervical lateral shows zygapophyseal. The oblique cervical shows intervertebral foramen. The T-spines, the oblique 70 to 75 degrees shows, and then the lateral shows intervertebral foramen. Okay?
296. The single most important radiograph for cervical spine series is a well-positioned lateral in which all 7 cervical vertebrae in the alignment of T1 should be demonstrated. Modeling the oblique position cervical spine demonstrates the cervical intervertebral foramen through which spinal nerves are transmitted.
Can everybody see the pedicles on 9-27? The little eyes out in front on the vertebral body, the little circles? On the vertebral body, those are pedicles, okay?
All thoracic vertebrae have facets for rib articulation, and the atlas or C1 has no body and no spinous process, but does have an anterior arch and a posterior tubercle with a bifid tip.
Okay, and this is all for cervical. Okay, so that tells us, he said an LPO shows what? The foramen on the right side. So if I'm in an LPO and we rotate me and come in here like that, left side's down, right side's up, so it shows upside on posterior obliques, side apophyseal. So what do you think it shows on anterior obliques? Okay, for cervical.
Okay, on 299, the thoracic spine shows the intervertebral foramina best in the lateral position to open up the cyclopophyseal joints. You need to open up the cyclopophyseal joints. You need a 70-degree oblique. Also, a 70-degree LPO will best visualize the cyclopophyseal joints on the upside. The opposite will be true for the anterior obliques, and the downside would be demonstrated.
Okay, so read through those two about upside, downside, and cervical and thoracic, and get that in your head. On side apophyseal.
Want those charts help you out?
Yes, they will.
Page 300. With also at level 210. This is the inferior end of the spine. The sternal angle is also called the angle of Lewis, and then the antebrum and body connect, which is inferior to the manual notch.
Okay. What level is the sternal angle thoracically?
T4?
T4, T5. Kind of cuts through the joint space. It begins at the lower half of T4, but then it cuts through the upper half of T5. Okay?
Page 301, positioning the patient in anterior obliques, RAO, and LAO positions will minimize the dose received to the thyroid gland, parathyroid, breast, and reproductive organs. T-spines are usually taken laying down with a 40-inch SID, whereas C-spines are taken erect at 72 inches to compensate for the increased OID from the neck to the image receptor.
Using higher tendons to advance tissue can increase production of spinal radiation. By using close pollination and a light blocker on the tabletop next to the patient's cavity radiation may be minimized. A third method is the use of grits. Number 2. A myogram is a fluoroscopic and radiographic examination of the spinal canal to evaluate lesions in the spinal canals, intervertebral discs, or mercuries.
Has anybody seen the myelogram yet?
Oh no, I saw arthrogram.
Well, there's not a similar
Yeah.
myelogram other than
It's just joint.
some radiologists want them to bring their knees up and turn on their side and place a spinal needle like an anesthesiologist does, and then other ones, older ones, want a pillow under their stomach and have them laying over it to arch the back, to have the needle placed in. If you haven't seen it, the needle's about this long. So you may get a little white flash, hot flash, or nausea. When you see them, they'll put the lidocaine in and they kind of pull up on the skin. It's like pulling on the skin like that.
Yeah.
And they're making a little pinwheel trying to deaden that area around there. Then they place the needle in, and then they kind of pull back and forth with it to try to get it in the joint. So don't just stare at the needle when they're doing it. Okay? Because I've had a student just funk out, and she was like, she just went on down. She just didn't like needles to begin with, and when she saw the skin pulling up and down, it made her sick. So be careful with that. Plus, you're in a lead apron, you're hot, and you're nervous. So be careful with those. What was that?
I was demonstrating how I would do it. I'm just playing.
Shannon, Dr. Taylor, can you do our monitor? She's going to stab you. All right. Okay.
Often with patients with osteoarthritis, compression fractures occur when one or more of the interior edges of the vertebral body collapse, causing a wedge-shaped body. And then patients with compression fractures will develop an exaggerated convex curvature in the thoracic spine called kyphosis.
Right, and that's where those bodies just compress on each other and it squeezes one down. They can do that when they have osteoporosis just by sitting on the commode. That does it. And now they do vertebroplasty to help them ease the pain there. But then once they start it, they're going to have it. They'll keep coming back. They're repeating.
This isn't important, but have you ever had to do an X-ray on somebody who's already deceased?
Oh, yeah. Burn victims, during car accidents, blew up, shooting victims. Used to do a whole lot more than they do now because the pathologist, Dr. Bruce, that was here, was a forensic pathologist and he could testify in court. Now, he finally got a bigger X-ray machine where he could X-ray the body instead of just bringing us along in a box with a, something in it. Otherwise, we had to push the portable out in the loading dock and they'd unzip the bag and we'd X-ray it. But they lifted them and did this stuff. We didn't have to touch them. But the burn victim was the worst. It smelled like, you know how those chicken trucks smell?
Oh, yeah.
That's what it smelled like. They had put fumigation stuff in it, but it's still. And it was just, I told them don't unzip the bag because I didn't want to see the
Right.
We had to X-ray the skull for dental and to do just a AP and a lateral.
And they moved it for you, the body.
So they have special places where they take people like that to X-ray?
I thought the morgue.
Or do they just take them to the hospital? Do morgues have X-ray machines?
No.
I mean, what's
We
the
don't have a morgue.
medical examiner?
We used to have,
Yeah.
years ago, we called it the boonies. We ended up filing X-rays in there when I was a student. Scary place.
A lateral curvature of the spine, which means that then side to side is called scoliosis. It then occurs in the lower vertebral column and creates a tilting pelvis, which then results in an uneven walk or a limp. It's more common in girls. And a type of arthritis caused by the breakdown and eventual loss of the cartilage of one or more joints is called osteoarthritis.
Right. And about the surveys, in the United States and Canada, the most common routine projections for the C-spine are the AP, 15 to 20 degrees, cephalic angle, AP open mouth, and lateral. But the swimmer's lateral is becoming more of a routine in the United States. And when it comes to obliques, the anterior oblique is becoming slightly more common than the posterior oblique. This is because the anterior oblique reduces thyroid dose.
Right.
We don't need to know any of that.
Here.
I don't know, it's just what
I know.
We
We do.
Cool.
On the AP open mouth projection, be sure to instruct the patient not to breathe, move, or swallow during exposure. And then again for the AP open mouth, make sure the mouth is wide open during the exposure and try to work fast because this position is uncomfortable for the patient.
Right. They have a tendency, especially when you've had a bump to your head, which means you've got a whip to your neck. You want to relax that. You don't want to open it wide either. So don't force their chin down, but just tap and say, okay, can you open wider? And see if they will. Okay?
Okay, I have the AP axial projection. When erect, you want to get an angle of 20 degrees cephalic and 15 degrees cephalic when recumbent. And don't forget to lower your SIDs when you're stable. And always collimate to the soft tissue border to reduce exposure to the patient.
Yeah, that's a good practice. But if you're still learning, you don't have to. Okay?
So for our practical, we don't have to
You don't have to
collimate?
collimate side to side to this neck tissue right here.
Oh, okay.
On the AP axial. On your odontoids, you have to go 5 by 5.
But the rest of them, if we want to leave it open.
9 by 9 or 10 by 12 cassette with a blocker at the bottom and mark the sides down. Number 2. When positioned correctly, posterior obliques will show the intervertebral foramina and pedicles of the side farthest from the IR.
So that's the upside. Okay?
Okay, for lateral position, cervical spine, the patient is in erect lateral position. The top of the eye is above, about 1 inch above the external acoustic meatus, and the CR is at C4. And for the second one, the shoulders should be relaxed, drop down and forward, and weights can be used if cervical surgery or injury is ruled out.
For the lateral position, horizontal leaning supine. You have to lateral supine for a consultation. Do not move the head, neck, or collar before conducting our position. And second one on the lateral C-spine, you'll have the hypothesis joint along the C1 and C7. If you cannot see C1 and C7, the mechanism is good.
Had to concentrate.
On page 311, for the planners, if you can't get C7 and C1 on the lateral cervical spine, and use the planners. But if you get a patient who can't move their arms down, can't move very well, you can angle your 3 to 5 degrees, separate their shoulders. And on this one, you can use a breathing technique to blow out the lung, or you can just use expiration.
The lateral hypoflexion position for the cervical spine should be aligned at the mid-coronal plane, center to C4, which shows the crest, and chin towards the chest to demonstrate the spine's process is open. The lateral hyperextension position for the cervical spine should also be aligned to the mid-coronal plane, center to C4, which shows the crest, and chin raised back as much as possible to demonstrate the spine's processes in close proximity.
Page 313. Each method will be performed to better demonstrate the dens and other structures of C1 and C2 when the AP open mouth fails to do so. And when performing the fuchs method, if the patient cannot tilt their head so that the MML is perpendicular to the tabletop, you must angle the CR to compensate and make it perpendicular.
When performing the AP wagging jaw projection of the cervical spine, you must adjust the head so that the lower edge of the upper incisors to the base of the skull is perpendicular to the table. And to shoot the AP Otonello, one must ensure only the mandible moves and that the teeth do not make contact while maintaining no rotation of the head.
Miss Wilcox, you said all we need to know on this one is that it's to blur the teeth, right? As far as test purposes?
What is it going to demonstrate?
Yeah, and what it demonstrates.
On the AP axial projection pillars, you must have the head back with the chin up in order to do the proper anatomy. Placing a pillow or towel under the patient's shoulders will help add part angulation to the less mobile patient. And also it's going to open up your metapophyseal joint. The second thing, CR to enter just under thyroid cartilage at 20 to 30 degrees caudal with patient not moving, breathing, or swallowing.
Okay.
On page 316 for the APC spine, you can use a 14x17 cassette, and you can column it to an 8x17. And the patient needs to be positioned on their back and align the MSP to the CR in midline of table with knees flexed to reduce the curvature of their spine. And the CR enters at T7, which is 3 to 4 inches below the jugular notch to ensure you can see C7 to L1, and the SC joints will be equidistant from the spine, indicating no rotation.
Page 317, the lateral position. Demonstrate a compression fracture, subluxation or kyphosis. You generally do a lateral thoracic spine with no rotation to the patient. And on the lateral thoracic spine, you will often not see T1 and T3 clearly, but intervertebral disc spaces should be open.
On 318, usually both anterior and posterior obliques of the thoracic spine are taken for comparing the zygapophyseal joints. When you're doing T-spine obliques, you mark the side down and create a 70-degree oblique from the plane of the table while rotating the body 20 degrees from the lateral.
I don't know if I worded it right, so these are oblique positions in order to demonstrate the zygapophyseal joint of the thoracic spine. If you are facing down or facing the IR with an anterior oblique, then the downside joint will be demonstrated. If you are facing up from the IR with the posterior Anterior oblique of the upside joint
Because if you look over here on her page, it says anterior oblique recumbent, LAO, RAO. Arm nearest the table should be down, and posterior arm nearest should be up. Okay? Then it says it doesn't tell you on there, does it? This says anterior breast doses lower. Pathology demonstrated involving all joints of the thoracic spine is demonstrated both right and left obliques are taken as comparison. Yeah, if your anterior, it should be the down. If your posterior, it should be the side up. It's on that chart.
It's on 319 IR.
Top structure shown, anterior oblique position.
Oh, okay, structure shown over on the other page. Okay, there it is, anterior oblique position demonstrates closest to the IR. So anterior is closest or down, posterior is up or closed. Okay, I was all looking on 318. Sorry about that. That's the end, right?
Yes.
So we ended there, so who's next? Joy? Not Joy, Joy.
There you go.